The third mechanism that can cause overnight blood glucose elevation is late evening food consumption or consumption of inappropriate foods at dinner that cause prolonged glucose absorption extending through the night. This seems straightforward, but the physiology and timing are more complex than most people realize. When you eat carbohydrates, those carbohydrates must be digested, broken down into monosaccharides like glucose, and then absorbed through your intestinal epithelium into your bloodstream. This process doesn't happen instantaneously. The rate of gastric emptying, the complexity of the carbohydrates, the presence of fiber and fat in the meal, and various other factors all influence how quickly those carbohydrates are converted to glucose and appear in your bloodstream. Simple carbohydrates like sugar or white bread are digested and absorbed relatively quickly, causing blood glucose to peak within 30 to 60 minutes after eating. But complex carbohydrates, especially when consumed as part of a mixed meal containing protein, fat, and fiber, can cause a much more prolonged glucose absorption pattern. Blood glucose might continue rising for 2 to 3 hours after the meal, sometimes even longer. If you eat a large dinner at 8:01 p.m. containing significant amounts of carbohydrates and then go to bed at 10 p.m., your body is still actively digesting and absorbing those carbohydrates while you sleep. The glucose from your dinner continues appearing in your bloodstream for hours after you've fallen asleep. In someone without diabetes, pancreatic insulin secretion would match this glucose appearance to maintain euglycemia. But in someone with diabetes, particularly with impaired insulin secretion and insulin resistance, this prolonged glucose absorption from the evening meal can cause blood glucose to remain elevated throughout much of the night. Many people check their blood glucose at bedtime, see a number in an acceptable range, and assume their glucose is controlled for the night. But they're checking before their blood glucose has peaked from dinner. They ate at 7:00 p.m., checked at 10 p.m., saw 140, and went to sleep thinking that was their highest reading. But at midnight, after more of the dinner, carbohydrates have been fully digested and absorbed, their blood glucose peaks at 190 or 200. It might come down somewhat by morning, but they wake up still significantly elevated at 165 or 170. Additionally, some people consume bedtime snacks, often with the misguided intention of preventing nocturnal hypoglycemia when hypoglycemia isn't actually a risk for them. These bedtime snacks, particularly if they contain significant carbohydrates, cause blood glucose elevation during sleep. A bedtime snack might be appropriate for someone at risk of nocturnal hypoglycemia, but for many people, it's unnecessary and counterproductive. The fourth mechanism involves medication-related issues, particularly timing, dosage, and duration of action. Different diabetes medications have different pharmacokinetic profiles, different durations of action, and work through different mechanisms. If your medications aren't properly timed or dosed to provide adequate coverage during the overnight hours when the dawn phenomenon typically occurs, or if medication action has worn off by the early morning hours, glucose control during this period will be inadequate. For example, metformin taken only in the morning may not provide adequate suppression of hepatic gluconeogenesis during the overnight hours. Intermediate-acting insulin taken at dinner time may have peak action in the middle of the night, but waning action by the early morning hours when the dawn phenomenon occurs. A sulfonylurea medication taken at breakfast will have diminished effect by the overnight period. Proper timing and selection of medications to provide optimal coverage during the critical early morning hours is essential but often overlooked. The fifth mechanism involves sleep quality, sleep disorders, and particularly obstructive sleep apnea. Sleep has profound effects on glucose metabolism and insulin sensitivity through multiple pathways. Poor sleep quality, insufficient sleep duration, and sleep disorders can all significantly impact overnight glucose control. During normal, healthy sleep, you cycle through different sleep stages, including light sleep, deep slow-wave sleep, and REM sleep. These different stages have different metabolic characteristics. Deep slow-wave sleep is associated with reduced cortisol secretion and improved insulin sensitivity. REM sleep is associated with increased sympathetic nervous system activity. Disruptions to normal sleep architecture can affect glucose regulation. Sleep deprivation and poor sleep quality increase cortisol and counter-regulatory hormone secretion. They worsen insulin resistance. They impair glucose tolerance. Even one night of poor sleep can measurably worsen insulin sensitivity the following day. Chronic poor sleep, which is extremely common in older adults, creates chronic metabolic dysregulation that contributes to elevated glucose throughout the entire 24-hour period, including overnight. Obstructive sleep apnea deserves special attention. In this condition, the upper airway repeatedly collapses during sleep, causing breathing to stop for periods of 10 seconds or longer, sometimes hundreds of times per night. Each time breathing stops, oxygen saturation drops. Each apnea event triggers an arousal response, a burst of sympathetic nervous system activity. These repeated arousals fragment sleep and prevent achievement of deep restorative sleep stages. The repeated hypoxemia and sympathetic surges associated with sleep apnea have profound metabolic effects. Each arousal causes release of cortisol, epinephrine, and other counterregulatory hormones. These hormones stimulate hepatic glucose release over the course of a night with hundreds of apnea events. Glucose can rise substantially from these repeated stress hormone surges. Additionally, sleep apnea worsens insulin resistance through multiple mechanisms, including oxidative stress, inflammation, and sympathetic overactivation. People with untreated obstructive sleep apnea often have substantial overnight glucose elevation that they cannot explain through diet or medication factors. They're not eating. Their medications seem appropriate, but their glucose rises significantly overnight due to the repeated metabolic stress responses triggered by their breathing cessations. And they typically have no idea this is occurring because they're asleep during the events. So you have 5 distinct physiological mechanisms that can cause overnight blood glucose elevation. The dawn phenomenon driven by circadian counter-regulatory hormone surges. The Somogyi effect from nocturnal hypoglycemia, triggering rebound hyperglycemia. Late or inappropriate evening food consumption, causing prolonged nocturnal glucose absorption. Medication timing or dosing issues, leaving inadequate coverage during critical overnight hours, and poor sleep quality or sleep apnea, creating hormonal disturbances that raise glucose. Most people with problematic overnight glucose elevation have more than one of these mechanisms operating simultaneously, which is why addressing the problem requires a systematic, comprehensive approach rather than a single simple fix. But Dr. Sarah is still not going to tell you the specific solutions yet. I'm still not going to tell you exactly what to do because the next critical step is identification. You need to know which mechanism or mechanisms are affecting you specifically because the therapeutic approach, the conversation you need to have with your doctor, depends entirely on which mechanism is operating. The treatment for dawn phenomenon is completely different from the treatment for Somogyi effect. If your doctor tries to treat one when you actually have the other, your control will get worse instead of better, and you could potentially be put at risk. Let me tell you about Robert to illustrate why this identification step is so critical. Robert was 71 years old with type 2 diabetes for 18 years. His morning fasting blood glucose was consistently elevated, averaging 174. His endocrinologist kept increasing his bedtime insulin dose, thinking more insulin would bring that morning number down and improve his control. But something strange was happening. Robert's morning blood glucose kept getting higher, not lower, as his insulin dose increased. At a bedtime insulin dose of 12 units of NPH insulin, his average morning glucose was 174. His doctor increased the dose to 16 units. Over the next 2 weeks, Robert's average morning glucose rose to 181. The doctor was confused, but thought maybe the increase wasn't enough. He raised the dose to 20 units. Robert's average morning glucose went up to 187. More insulin was making things worse, not better. This made no logical sense to the endocrinologist. Insulin should lower glucose. Increasing the dose should improve morning numbers, but Robert's numbers were deteriorating. The doctor was considering adding yet another medication, maybe switching to a different insulin formulation, adding metformin at bedtime, trying anything to get those morning numbers down. But nobody stopped to ask the critical question: what's actually happening overnight? Where is this glucose coming from? Is this truly inadequate insulin coverage, or is something else occurring? When we finally had Robert check his blood glucose, not just at bedtime and morning, but also at 3 a.m. in the middle of the night, the truth became immediately clear. His bedtime glucose at 10 p.m. was 145, acceptable. His 3 a.m. glucose was 52, severely hypoglycemic. His morning glucose at 7 a.m. was 187. The pattern was unmistakable. Robert was experiencing the Somogyi effect. His insulin dose was causing dangerous nocturnal hypoglycemia around 2 to 3 a.m., dropping him into the 50s. His body was launching a massive counterregulatory response. By morning, his glucose had rebounded into the 180s, and every time his doctor increased his bedtime insulin, he made the nocturnal hypoglycemia worse, which made the rebound worse, which made the morning numbers worse. They were treating the problem with more of what was causing the problem. It was a dangerous cycle that could have resulted in severe hypoglycemia with seizures, loss of consciousness, or even death. Once we recognized the Somogyi effect, the solution became clear. Robert worked with his endocrinologist to reduce his bedtime insulin dose back down to 8 units. They had him check his 3 a.m. glucose several more times to ensure he wasn't going hypoglycemic overnight. At 8 units, his 3 a.m. glucose was 102 safe, and his morning glucose improved to an average of 143. Still not perfect, but 44 points better than it had been on the higher insulin dose. He was safer, and his control was actually better on less medication. This is why identification is absolutely critical before attempting any intervention. You cannot fix what you haven't properly identified. Comment if you've had the experience of getting worse control despite increasing medication doses. Type worse with more meds if this describes your situation. This is a critical warning sign that deserves investigation for possible Somogyi effect. Before I explain the identification strategies and the types of discussions to have with your doctor, I want to make a request. If what you've learned so far has been valuable, if you're finally understanding the complex physiology behind overnight glucose elevation and why it's not simply a matter of poor control or needing more medication, I'm asking for 2 actions. First, consider subscribing to this channel if you haven't already. Dr. Sarah's mission is to provide detailed, mechanism-based, physiologically accurate health education that helps you understand what's actually happening in your body. Information that empowers you to have more informed, more productive discussions with your healthcare team. Information that goes beyond superficial advice and actually explains the underlying science. Second, please share this video. Think about your friends, your family members, anyone with diabetes who's dealing with elevated morning blood glucose and doesn't understand why it's happening or feels defeated by it. How many people are suffering with this problem unnecessarily, not understanding the mechanisms, not knowing what questions to ask their doctors? A simple share could provide someone with the understanding they need to finally address this effectively in partnership with their healthcare provider. And if you want even more detailed diabetes management education, Dr. Sarah has created something special for this community. I'm working on a comprehensive ebook about blood sugar control, diabetes management strategies, and preventing complications specifically for people over 60. It will contain detailed physiological explanations, monitoring protocols, questions to ask your healthcare team, and evidence-based information about all aspects of diabetes management. If you want to be notified when it's ready and receive exclusive health information Dr. Saira can't fit into videos, join my free newsletter. The link is in the description below. No spam, no selling, just valuable educational content, updates on research, answers to common diabetes management questions, practical information you can use to work more effectively with your healthcare providers. Thank you for your support. Now let me explain exactly how to identify which mechanism is affecting you and what discussions to have with your doctor. The fundamental principle is this: you cannot identify what you don't measure. You need data. You need to understand what your glucose is actually doing throughout the overnight period, not just at bedtime and in the morning. This requires checking your glucose at strategic times to reveal the pattern. The standard monitoring protocol Dr. Saira recommends discussing with your doctor is this. For 1 week, check your blood glucose at 3 specific times. First, at your usual bedtime, typically around 10 p.m. Second, in the middle of the night at approximately 3 a.m. Yes, this requires setting an alarm and waking yourself up specifically to check your glucose. It's disruptive and inconvenient, but it's essential, and it's only for 1 week. Third, at your usual wake time in the morning, typically around 6 or 7 a.m., these 3 data points measured over several nights will reveal the pattern and tell you which mechanism is operating. If your bedtime glucose is around 135, your 3 a.m. glucose is around 140, and your morning glucose is around 175. That's the classic pattern of the dawn phenomenon. Your glucose is relatively stable through most of the night, but rises significantly in the early morning hours between 3 a.m. and 7 a.m. The 3 a.m. check is normal, but by morning it's elevated. This indicates your body's circadian counterregulatory hormone surge is causing hepatic glucose release that your diabetic metabolism can't compensate for. If your bedtime glucose is around 135, your 3 a.m. glucose is around 60, and your morning glucose is around 175. That's the pattern of the Somogyi effect. You're dropping into hypoglycemia in the middle of the night, then rebounding with counter-regulatory hormone responses that drive your glucose high by morning. This pattern indicates you need to discuss with your doctor about reducing evening medication doses or implementing a small appropriate bedtime snack to prevent the nocturnal hypoglycemia. If your bedtime glucose is around 135, your 3 a.m. glucose is around 165, and your morning glucose is around 160. This suggests prolonged glucose absorption from your evening meal. Your glucose is peaking hours after eating and staying elevated through much of the night. This pattern indicates you need to discuss with your doctor about dinner timing, dinner composition, or possibly adjusting the timing of medications to better match your food intake. If you have sleep apnea or poor sleep quality, you might see erratic patterns with glucose rising and falling throughout the night, corresponding to apnea events and arousals. Or you might see sustained elevation related to chronic elevation of counter-regulatory hormones from sleep disruption. These patterns give you and your healthcare team critical information about what's actually happening physiologically, which then guides what therapeutic discussions to have. Now let me explain what types of discussions and approaches your doctor might consider for each mechanism based on current medical evidence and guidelines. Remember, Dr. Sarah is providing educational information about general approaches, not telling you to do any of these things. All decisions must be made by your physician based on your individual situation. For the dawn phenomenon, there are several potential therapeutic strategies your doctor might consider. One approach is adjusting the timing of existing medications. If you take metformin twice daily, taking the second dose at bedtime instead of at dinner might provide better suppression of hepatic gluconeogenesis during the critical early morning hours. If you're on a once daily long-acting insulin, some patients do better taking it at bedtime rather than in the morning to provide peak action during the dawn hours. Another approach is adding or adjusting basal insulin specifically to cover the dawn phenomenon period. Some patients benefit from split dosing of NPH insulin with a small dose at bedtime specifically to provide coverage during the 4 to 8 a.m. window. Some do better with long-acting insulin analogs like glargine or detamir that provide relatively flat action profiles throughout 24 hours. Some patients benefit from adding or adjusting GLP-1 receptor agonists, which can help suppress hepatic glucose output and improve overnight glucose control. These are discussions to have with your endocrinologist about which medication adjustments might be appropriate for your specific situation. For lifestyle approaches that can complement medical management, some evidence suggests that exercise in the evening, perhaps a 20 to 30-minute walk after dinner, can improve insulin sensitivity for 12 to 16 hours afterward, extending through the night and into the next morning. This improved insulin sensitivity can help your body better handle the dawn phenomenon glucose surge. Eating dinner earlier and keeping carbohydrate portions moderate at dinner may help by reducing the amount of substrate available for hepatic gluconeogenesis overnight. But these are gentle supportive measures, not replacements for proper medication management when needed. For the Somogyi effect, the primary approach is preventing the nocturnal hypoglycemia that triggers the rebound. This often involves working with your doctor to reduce evening medication doses. If you're on bedtime insulin, the dose may need to be reduced. If you're on a sulfonylurea medication, taking it at a different time or reducing the dose might be appropriate. Some patients genuinely do need a small bedtime snack to prevent overnight hypoglycemia, but this needs to be discussed with your healthcare provider. The snack would typically be something containing both protein and complex carbohydrate to provide sustained glucose without causing a spike. Perhaps a small amount of peanut butter with a few whole grain crackers. But adding a bedtime snack when you don't actually have a hypoglycemia risk can worsen control. So this should only be done based on actual monitoring data showing nocturnal lows. For late eating or inappropriate evening meals, the discussion with your doctor centers on dinner timing and composition. Eating dinner by 6 or 7 p.m. when possible. Allowing 3 to 4 hours before bed gives your body time to digest and absorb that meal while you're still awake. You can see your peak post-dinner glucose, and it has time to come down before you sleep. Discussing with your doctor or a diabetes educator about appropriate dinner composition might be helpful. Keeping carbohydrate portions controlled, emphasizing protein and non-starchy vegetables, including some healthy fat for satiety. All of these can help moderate the post-dinner glucose response and prevent sustained elevation overnight. For medication timing issues, this is entirely a discussion for your healthcare team. Your doctor may consider adjusting when you take your medications to better match your eating patterns and to provide optimal coverage during the overnight and early morning hours when you need it most. For sleep apnea and sleep quality issues, this requires addressing the underlying sleep disorder. If you snore loudly, wake up gasping, or feel unrefreshed despite adequate time in bed, discussing sleep apnea evaluation with your doctor is important. Sleep apnea is diagnosed with a sleep study, either in a sleep lab or increasingly with home sleep testing. Treatment of sleep apnea, most commonly with CPAP therapy, can significantly improve overnight glucose control in people who have both diabetes and sleep apnea. Some studies have shown improvements in hemoglobin A1C and fasting glucose after effective sleep apnea treatment. This is addressing a root cause rather than just treating the symptom. Improving sleep quality through good sleep hygiene practices, maintaining consistent sleep schedules, creating an optimal sleep environment. These can all support better metabolic function overnight. Some patients ask about supplements like magnesium. Magnesium deficiency is common, and magnesium does play a role in glucose metabolism and insulin function. If you're interested in discussing magnesium supplementation with your doctor, Typical doses for adults are 300 to 400 mg daily, often taken at bedtime. Magnesium glycinate tends to be well absorbed and less likely to cause digestive upset than other forms, but always discuss any supplementation with your physician, particularly if you have kidney disease or are on medications that affect magnesium levels. Let me return to Margaret, whose story Dr. Sarah told you at the beginning. Margaret's monitoring revealed a clear dawn phenomenon pattern. Her bedtime glucose averaged 138, her 3 a.m. glucose averaged 142. Her morning glucose averaged 178. She was stable through most of the night, but experiencing significant elevation in the early morning hours. Working with her endocrinologist, they made several adjustments over time. First, they switched her metformin to the extended-release formulation and moved one dose to bedtime to provide better overnight hepatic glucose suppression. Second, they adjusted her meal timing, having her eat dinner by 6:01 p.m. when possible. Third, she added a 30-minute walk most evenings after dinner. These changes, implemented systematically, dropped her average morning fasting glucose from 178 to 132 over about 3 months. Not perfect, but a substantial 46-point improvement that made her feel empowered and hopeful. Robert's Somogyi Effect was addressed by reducing his bedtime insulin dose and ensuring he wasn't experiencing nocturnal hypoglycemia. His morning glucose improved by over 40 points simply by giving him less insulin, which seemed counterintuitive but made perfect physiological sense once the mechanism was identified. Today we've covered the complex physiology of overnight glucose elevation. The dawn phenomenon driven by circadian counter-regulatory hormones, the Somogyi effect from nocturnal hypoglycemia, triggering rebound hyperglycemia, late eating causing prolonged overnight glucose absorption, medication timing issues, and sleep disorders, particularly sleep apnea. You've learned that these different mechanisms require different approaches, which is why identification through strategic monitoring is so critical. You've learned about the types of discussions to have with your healthcare team based on which pattern you're seeing. Dr. Syra's message isn't to adjust your medications yourself or to try to treat this without medical supervision. These are complex physiological processes that require professional medical management. My message is empowerment through understanding. You now comprehend what's happening inside your body overnight. You know what monitoring data to gather. You know what patterns to look for. You know what questions to ask your doctor and what discussions to initiate with your healthcare team. Implement the monitoring protocol I described. 1 week of checking at bedtime, 3 hours a.m. and morning. Gather the data, look for the patterns, then schedule an appointment specifically to discuss these findings with your endocrinologist or primary care physician. Show them the data. Discuss which mechanism seems most likely. Ask what therapeutic options might be appropriate for your situation. Share your experience in the comments. Which mechanism do you think might be affecting you based on what you've learned? Have you done the overnight monitoring? What patterns are you seeing? Your stories and questions help create a community of informed patients who can support each other and share experiences. If you haven't already, join my free newsletter community. The link is in the description. Dr. Syra shares detailed diabetes management education, updates on research, and evidence-based information about all aspects of diabetes care. You'll be first to know when my comprehensive diabetes ebook is released with complete physiological explanations, monitoring protocols, and strategies for working effectively with your healthcare team. That first step you take today, committing to 1 week of systematic overnight monitoring, could finally solve the mystery of your overnight glucose elevation. The difference between waking up to 175 or to 125, between feeling defeated every morning or feeling informed and empowered, between continuing progressive complications or gaining better control. The power lies in understanding the physiology and working effectively in partnership with your healthcare providers. Final critical reminder, this information is strictly for educational purposes and should not be considered medical advice. Dr. Sarah is not your personal physician and cannot provide individualized medical guidance. Never adjust your diabetes medications without direct supervision from your healthcare provider. Never change insulin doses on your own, as this can cause life-threatening hypoglycemia or diabetic ketoacidosis. The monitoring strategies and physiological explanations I've shared are meant to facilitate informed discussions with your doctor, not to replace professional medical care. Diabetes management is complex and must be individualized based on your complete medical history, your specific type of diabetes, your other health conditions, your medications, and many other factors that only your physician can properly evaluate. Always work closely with your endocrinologist or primary care physician for all diabetes management decisions. Take care of yourself. Gather the monitoring data this week. Schedule that discussion with your doctor. Work in partnership with your healthcare team, and I'll see you in the next video where we'll continue this mission of diabetes education together.